Get started. So I want to thank everyone for joining me this morning. Spend a good hour talking about the transport of the neurocritically ill patient, and hopefully there'll be some common threads here between transport medicine, neurology, neurosurgery, critical care, and you can kind of get a chance to see how it all weaves in together. So nothing to disclose, no financial disclosures. I'm happy to have some if anyone knows any. But I am a private pilot myself, and I do fly with Airlift Northwest. And so I will be nerding out heavily on in-flight stuff. And just as an aside, some of the most amazing scenery on the planet is right here in the Pacific Northwest, especially at 2,500 feet. So this is all based off of data that's about 10 years old now, but the majority of Americans, at least 10 years ago, did not live within a reasonable distance of a neuro ICU. A third of the people only lived within an hour and a half. However, if you bring air transport into the mix, that population increases significantly. Now, this is based on 2012 data, and as we all know that post-Dawn and Diffuse and the thrombectomy trials came out in 2018, there has been a large increase in the number of neuro ICUs around the country. And areas that have no representation here now actually have quite a few neuro ICUs. However, not all units manage all disease processes, and not all areas are still well represented. There's still a paucity of care in a large part of the country. And transport times vary significantly depending on what region you're in. And as we'll talk about, just because you're in New York City does not guarantee that you're going to get to a hospital in a reasonable time frame. So specialized care matters depending on whether you have a stroke or traumatic brain injury, or if you're in status, spinal cord injury. It's not just about the medicine, it's about all of the other things that a high quality neurocritical care unit at a major center can offer you. And so while some ICUs may be nothing more than a stroke unit that can take care of post-thrombectomy patients, others like ours have advanced capabilities, include advanced neuromonitoring, continuous EEG, the nursing staff that are neurocertified and trained, and then a complete rehab specialty that can take care of these patients once they're ready to leave the acute care phase of their illness. And it's been shown repeatedly through the years in the last 2 years, that neurointensivists and neurocritical care units do improve outcomes for critically ill neuro patients. And the longer it takes patients to get there, the worse their outcomes are. And this all goes under the central thesis of access to specialty care and procedures save lives. And we've known this for quite some time. Mike Diringer at WashU has shown this, that patients admitted to a general med surg unit versus a dedicated neuro ICU with a neurointensivist actually do better in that setting. And a meta-analysis came out last year that showed the same thing, that over 2 decades of neurocritical care being a specialty, that specialty care does save lives, that access to access to specialized resources improves outcomes, save lives, and patients do better in these types of settings. And so if we know that patients do better at these specialized care centers, it's, well, how do we get that care to patients? How do we get patients to definitive care as fast as possible? And there's really 2 ways to approach this. Way number 1 is to bring that definitive care to the field, and that requires more specialized care in the pre-hospital setting. And this is largely the Franco-German model of EMS, where they bring the entire hospital and specialized care to the bedside to you, or in the case of these anecdotes in Paris, to the Louvre or to the Paris Metro, where now they're doing field ECMO cannulations with a decent acceptable rate of survival to neurologic discharge. The flip side of this is that you need a highly trained group of individuals, complete with all of the equipment, all of the support staff, all of the resources to be able to do their job in the field. Otherwise, you get sort of random yahoos who are drilling in the absolute inappropriate spots if they don't know what they're doing. The other way to do this, though, is to get there faster, get patients to their destination as fast as possible. Time as brain has sort of permeated the stroke world. That golden hour of neurotrauma is present as well, although there's some debate about whether that's true or not. But the fact is that the faster we get patients to definitive care at the hospital, the better the chance that they have of recovering from their injury. So I want to take a step back and talk a little bit about the history of aeromedical transport. This is Christoph 1, and in German aircraft and vessels use the male pronouns. So Christoph 1 was the first air ambulance, and this is him stationed here in his modern incarnation. But back in the 1970, when Christoph 1 was first released and first put into commission, this is what he looked like back then. And Christoph 1 is still stationed at Harleking Hospital in Munich, Germany, and it was the first civilian air ambulance set up in the world. But to go back to the history of aeromedical transport, we actually have to go back to World War I, where the first record of a soldier transported by air was in 1917 in the Sinai Desert, where a camel horseman in the Imperial Army has its ankle shattered, and instead of the 2 to 3 days of transport by ground to the local field hospital, the patient was put into a biplane and flown to the hospital, which only took 45 minutes. So this was the first time anyone ever thought, hey, we've got these airplanes, maybe we can transport our injured soldiers by air instead of by ground. And this sort of set off a revolution of air transport that progressed through World War I, World War II, the Korean War for the US, where we really started to assert our air superiority, and the French in the Indochina Wars in Vietnam. The first use of medevac with helicopters was was actually by us, but with British Army casualties during World War II, where we evacuated 3 combat casualties by a Sikorsky in Burma. So again, this has continued, and now we have a very modern, very active aeromedical evacuation group in the military. Critical care air transport team is a very robust transport team in the US Air Force. And the care that we provide our injured soldiers is just phenomenal. And has its legacies way back in World War I. On the civilian side, though, the story is actually more interesting than this. So Reverend John Flynn formed the Australian Inland Mission Aerial Medical Service in Queensland on May 15th, 1928. And the origin of this actually goes back even a decade further. This is John Flynn with some of his colleagues. In the modern incarnation of this is the Royal Flying Doctor Service in Australia. And so to go back to 1917, on the 29th of July, there was a man named Jimmy Darcy who was crushed by his horse in Kimberley in Western Australia. And he was taken to the nearest settlement in Halls Creek, which, if you've ever looked at a map of Australia, is quite literally out in the middle of nowhere. This was the nearest settlement where any sort of care could be provided, but there was no physician there at the time. And the closest doctor was in Perth. And what had to happen was the local postmaster named Fred Tuckett had to anesthetize the patient with morphine, use his brothers to help restrain him down, and use a penknife and whatever else he could find to operate on the patient to save his life by fixing his ruptured bladder. And he did so by using instructions from the physician, who was named Dr. Joe Holland from Perth, by Morse code, by telegraph. So if you can imagine from the faculty standpoint, teaching your residents how to operate in person, imagine now doing it by telegraph from thousands of kilometers away. So the fact that this man survived that operation is a small miracle in and of itself. Dr. Holland then tried to travel from Perth by boat, by horseback, by a Model T that was falling apart. He actually had to take his stethoscope to siphon off gas from a canister to try to get there as much as he could, and then ended up walking the last 2 days by foot. Unfortunately, the patient died of malaria before he could get there. But the story here is what prompted a lot of people, especially a medical student in the Australian Army, to think, hey, is there a better way we could do this? Could we maybe use our aircraft to get medical care to remote facilities? And thus the Royal Flying Doctor Service was born. It's also the first time in recorded history that this ICD-10 code was able to be used, struck by horse. Walked into lamppost, I think, came later. But as I said, unfortunately, James Darcy died, but his legacy lives on in the Royal Flying Doctor Service. And just to give you a sense of how far we're talking about, it's almost 2,500 kilometers away, literally in the middle of nowhere in Australia. And I don't know if anyone here has been to Australia. I have not, but it's remarkable just how big the continent is, and it's the maps really don't do it justice. If you're going to drive there, it still takes 29 hours to drive from Perth, and if you get there from the closest airport, you're still 7 hours away. So the fact that this patient was able to survive an operation using morphine and a penknife is somewhat remarkable. So as we've talked about that, that's the history of aeromedical evacuation. And so let's talk about sort of the things that we think about in the modern era in terms of actually transporting the patient from point A to point B. So there's several things that I want to cover and several important domains to think about when we're transporting a patient. And the first is altitude. So as we go up in altitude, the air pressure drops, the amount of oxygen drops, the percentage stays the same, but the amount that's available drops. And hypoxemia is a very real concern. This was a military study that looked at cabin altitude restrictions, and they flew patients in aircraft that had no altitude restrictions and those pressurized with a max pressure altitude of 5,000 feet. And obviously those who were in pressurized cabins with a max altitude had fewer episodes of hypoxemia, but fortunately the outcomes were about the same. Now, only 3% of patients in the study had hypoxemia, but it does go to illustrate that pressurization actually is important and does help. This is another military study looking at Air Force transports with CCAT and how many legs that a soldier has to fly in order to get from the field to the definitive care. And found that hypoxemia does occur at nearly every leg. Leg 3 happened to be CCAT, so that's less of an issue. But even with helicopter transport, it's a real problem. And as we know, prehospital hypoxemia does actually affect outcome. And over a quarter of patients had at least one episode during transport in nearly every study that's been done. And outcomes are worse, and there is an increased mortality with even a single episode of hypoxemia and traumatic brain injury. We don't actually know what the appropriate target is that we need to achieve, but we do know that hypoxemia does worsen outcomes, and it is something that should be avoided. With altitude, however, also comes Boyle's law. And as you start increasing your altitude, your pressure drops and thus your volume expands. And therefore, if you have a patient who lives on the other side of the Cascades that had a neurosurgical operation with pneumocephalus, headaches, and needs transport, this is a tricky patient to fly over the Cascades. This is not someone that you want to put in a helicopter. I don't know anyone that would feel super comfortable taking this patient up to a pressure altitude of 4,000 to 8,000 feet. Even if they're on the east side, is this someone that you really want in a helicopter taken up to 1,500 feet or 2,000 feet? Well, fortunately, we have data for that. This was a pneumothorax model done where they took a fake pneumothorax, a fake lung, and put it on a helicopter, took it up to altitude, and found that for every 500-foot increase in altitude above ground, that the size of the pneumothorax actually increased in a significant fashion. So altitude actually does matter. And if you have air in a body cavity, you should be very, very wary about taking patients up at altitude. This was simulated in this study because it's really not ethical to take people with intracranial air up at altitude to see what happens to them. So this was simulated with a computer model, and they found that even the smallest amount of air does increase. But what they found was that the amount of air that you had actually was affected by altitude and increased almost exponentially. So that the models that had more air had higher ICPs that increased more rapidly as you ascended. So this is a real problem and something to think about. And when you're putting a patient on the back of a helicopter with air, is something to really think about. Is this the right move for the patient? Should you instead transport this patient by ground? Is this someone that should go in a fixed wing cabin that can be pressurized? All things to think about, all things to kind of ponder as you're mulling over the transport of this patient. No discussion of aviation would be complete without talking about weather. This is a much larger topic, but weather is a big, big deal. And it's not just bad weather. In one study, a third of flights had to be canceled because of weather-related issues. But it's not just about air transport. Ground transport isn't immune to bad weather either. Snowstorms, blizzards can significantly affect the ability of ambulances to get from point A to point B. And this happens whether you're in the wilderness of West Virginia or if you're in downtown Manhattan, where In the Snowmageddon of 2016, ambulances got stuck and couldn't go. Snoqualmie Pass, we all know how hard it is to get patients transported over by ground during the wintertime when the pass is closed. So this affects ground transport as well. And it's not just about snow in the northern climates. Our neighbors to the south actually have significant problems with rain and with hurricanes, and that can prevent ambulances from getting from point A to point B. This is the most recent hurricane in Florida that caused havoc throughout the state. And even just traffic makes it a big deal. If you're in downtown Manhattan on a Friday afternoon at 3 p.m., good luck moving 2 blocks. And so are you really better off there where there's a hospital every couple of blocks, or are you better off in the Pacific Northwest where you have remote access to care, but we have a robust pre-hospital flight network that can get you from point A to point B? And so these are all the challenges that have to be considered when you're thinking about putting a patient either on a helicopter and even in the back of an ambulance. What's the situation? How long is it actually going to take to get there? Density altitude is an important aviation concept to talk about. But before we get there, I want to briefly talk about weather, temperature, before we transition to density altitude. Most drugs have some degree of temperature stability, but mannitol, as we all know, does crystallize when it's not in a warm, heated environment. And nicardipine degrades when exposed to light, so it has to be kept in a darkened bottle. There are wide temperature fluctuations when EMS bags with drugs are left out and about into the environment. And this was a study that looked at, the only real way to control the temperature of a vial of medication is to keep it in a refrigerator in a pharmacy. Basically anywhere else, it's going to be exposed to wide temperature fluctuations. This was a Swiss study that looked at changing temperatures throughout the seasons at a midland base versus a mountain base, and found wide temperature fluctuations from as low as 10 degrees Celsius down to freezing all the way up to 30 degrees Celsius, which in Fahrenheit is somewhere in the 90s to hundreds. Fortunately, most drugs are temperature stable and retain their activity and pharmacokinetic properties despite wide range of temperature fluctuations. But it is important, and one of the things that we do in the EMS setting is make sure that our drugs have not expired. If drugs have been sitting out in the environment for quite some time in the med bag, we kind of think about maybe it's time to replace these, and oftentimes we'll end up replacing drugs well before their expiration date. So temperature is a big deal, not just for medications, but for density altitude as well. And just as a primer here, true altitude is your height above sea level. So right now we are in Renton, I'm about 100 feet above sea level. At Harborview, we're closer to sea level. If you're out in central Washington, you may be a couple thousand feet above sea level, depending on where you are. But pressure altitude is the height above a standard datum plane. And this is what the airplane flies at. So every time you get into an airplane, the pilot's listening to the barometric pressure on the weather and setting the airplane's altimeter, and the airplane flies at these pressure levels based on the standard datum plane. And density altitude is that pressure altitude corrected for standard temperature and humidity. So the hotter the day outside, the higher the plane thinks it's going to be flying at. And this is a big deal. So this is how it's related. You've got the standard chart of temperature based on a standard lapse rate of temperature. You can plot this on a graph. And what we do is, if you're flying at a pressure altitude of 10,000 feet, which is probably close to actual altitude of 10,000 feet on any given day, you factor in your outside air temperature and you say, all right, it's 10 degrees Celsius right now outside, which is pretty hot for 10,000 feet. I'm flying at 10,000 feet pressure altitude, which means that my density altitude is actually close to 12,000 feet. So my plane thinks it's flying at 12,000 feet, even though I'm not actually flying at that altitude, but it's the engine is behaving that way, and its performance is affected by that, which means that my true airspeed, how fast I'm going, how much fuel I'm burning is affected, how far I can go, how quickly I can get up at altitude, what my cruising altitude can be. If I'm exceeding the threshold of the aircraft's performance, I can't even get up to an altitude. And if that's not high enough to clear mountains, I'm not flying across the pass that day. It can affect your destination airfield because it's going to affect your takeoff distance and landing distance. So if you're trying to get to a smaller community airfield to pick up a patient, you may not be able to do that in a fixed wing aircraft. You might have to do that in a helicopter. So that all that is affected by just weather itself. And it's not just the EMS world that's affected by this. This is affecting commercial travel as well. High temperatures will ground aircraft, and this is more common in the Southwest, where temperatures can get well into the hundreds and 120s in the summertime. But as climate change progresses and more extreme weather forces are being observed, this is going to be more of a problem as the years progress, and it's going to affect EMS transport as well. And then lastly, headwinds are a big deal. If you have a really, really nice tailwind, you may get to your destination real quickly to pick up your patient. But on the way back, it's going to be painful because now that tailwind that was getting you to your destination is now a headwind. And that's going to affect your transport time, which means you have to make sure you have enough sedation to sedate the patient that entire journey. Do you have enough paralytics if the patient's not allowed to move? Do you have enough oxygen supply? If it's a long transport, are your oxygen canisters filled and charged and ready to go? All these things are things that are important to think about. And then finally, do you have enough fuel to make the trip? Do you have to make a fuel stop because you've burned so much fuel just fighting the headwind that now you have to land somewhere at an airport, refuel, and then take off and get to the patient? All of these things are important to think about, and stuff that our pilots, as we're talking about the medical things, our pilots are actively doing these calculations to figure out if the flight's even doable. So transport time is a big deal. We all talk about how flight transport is super, super fast, way faster. It's the fastest way to get someone from A to B. While that may be true, there are other things to think about, and it's not just about speed. If you are in a community hospital somewhere in the middle of nowhere and you want to transport someone by ground, it's easy. Ambulance comes to your hospital, picks up the patient, drives the patient to the destination hospital. And they're going pretty fast. They're doing about 55 to 70 miles an hour, and they can go about 250, 300 miles at that rate. And they need more gas. They just pull over at a gas station, stop, get more gas, and keep driving on. Not a big deal. If there's any emergencies, they pull off to the side of the road, handle the emergency, and take care of the patient. Rotorcraft, however, is a little bit more complicated. Sometimes helicopters are based at airports, but not often. And when that's the case, the helicopter has to be dispatched, fly to the scene, fly to the hospital, wherever the patient is, then fly to the destination facility. And in the case of Harborview, land, shut down, wait for an ambulance, get into the ambulance to drive across the block. Hopefully that's changing with the new tower, but for now, that's the reality. But helicopters can go faster. They can go a lot faster, and their range is very similar to ambulances. Flip side is you can't just pull over to the side of the road and deal with an emergency. You have to land, and gas is a little bit more complicated. You actually have to get to an airport to get gas if you need to refuel. Fixed wing transport is obviously the fastest, but there are few, if any, airports that are right next to a hospital or have a hospital as part of their facilities. And so inevitably the patient ends up needing to get into an ambulance, drive to the airport, get on board the aircraft, take off, fly to the destination airport, land, get into an ambulance, and then drive to the destination hospital. All of this adds an extra amount of time. Now the range is way, way more than anything else. So if you're flying from Alaska on our Learjet with airlift, makes perfect sense. That's really the only way to get patients to Seattle. But if you're flying from Bellingham or if you're flying from Olympia, yeah, maybe that's going to be great, but it might just be faster to put the patient on the back of an ambulance and just drive as quickly as you can down I-5, especially if it's not a great day to fly, if the weather's not ideal, that may be the safest option. So all things to think about whether it's appropriate to even fly the patient. And when you're talking about flying, it's more to ask the question of, is it really even worth it? This is a number of neurology studies showing that, well, maybe it could be that getting stroke patients to their destination facility for thrombectomy may actually be important. And maybe there are time-sensitive interventions that could be warranted and patients could do better. This is some neurosurgical data that looks at the same idea, that maybe getting patients to a level 1 center or a level 2 center actually does improve outcomes, and getting them there faster by aeromedical transport is actually important. Galvagno actually looked at this and found a number needed to treat of 65, which in the scheme of things is actually not that bad. For every 65 patients that you transport by air, you'll actually help one patient and improve their outcome. not the number needed to treat for something like tobacco cessation with a number needed to treat of 7, but certainly better than a lot of things that we do. But on the flip side, other data show that it may be mixed and that benefit may not be there. So it's a lot more complicated than just saying, oh, it's faster, we can get patients to our destination facility as fast as possible. Now, the calculus gets a little bit more complicated because dispatch times do count. If the helicopter is unavailable and you have to wait an hour for the helicopter to get to your facility, is that really going to save you time? But on the flip side, if you were at a small community in Orcas Island and you have to wait for the ferry, well, that's not helpful. Or if you're in a small community that only has one EMS rig and you have 2 volunteer EMS folks that are doing the best they can, removing that ambulance from that community basically eliminates all emergency medical care in that community for while that ambulance is out. And so sometimes a helicopter coming in to take that patient can actually save that community the loss of an ambulance for several hours. So it's all of these things are sort of things in the background that we think about, and what is the best way to transport these patients. Again, we've talked about headwinds, how weather can affect transport time. It can make it longer. If you're dealing with a bad headwind, this can be a big deal. If you have a bad weather system and a bad cold front that's coming in that you have to fly around, that can affect your transport time as well. Sometimes it's better to just put the patient in an ambulance and drive as fast as you can. If the weather sucks and you can't even launch, it doesn't matter how fast you can go, you're just not flying. Flight crew have FAA mandated downtime. And if your pilot is timed out, if your flight crew is timed out, that aircraft may not be in service until they have their mandated rest period. And at that point, you don't have a choice. You have to drive the patient. And then, of course, emergencies during transport. I don't know if anyone here has done CPR in the back of a moving ambulance. It's not fun. People get motion sick very quickly, and it's best to just pull off to the side of the road while you do that. In a helicopter, same idea. You don't want to be doing emergent medical things, intubating, doing CPR in the back of a helicopter while it's in motion. You got to land to do that. And it's not that easy to just pull over to the side of the road to do that in a helicopter or in a fixed wing aircraft. So let's talk about the equipment itself, the airframes themselves. There's not a whole lot of room. I know there's quite a few military people in attendance here that have served, and I'm sure you guys have been in the back of these helicopters. There's no room. You barely have enough room for the crew. You barely have enough room for the equipment that you're taking on. And if you didn't take that piece of equipment with you, you don't have it on board, which means if you suddenly need something, you can't produce it. You can't just stop at a hospital on the way and pick up a piece of equipment that you may have left behind or that you don't have. Same thing with medications. If you don't have enough drug on board, you're out of luck. There's not much you can do at that point. And ultimately, the aircraft does have space and weight limitations. There is a maximum load that the aircraft can carry, and it has to carry the pilot, 2 flight crew, the patient, and enough fuel to get to your destination, along with all of the equipment that's on board. So that's important to think about. There is a weight restriction. On airlift, we can transport about a 250-pound patient, and that's really not much more than that. Patient positioning is important too. Head of bed 30 to 45 degrees for a patient in an ICP crisis may not be feasible, depending on the aircraft that we're transporting on. This is the back of our Learjet. As you can see here, there's no room back here. The entire left side of the patient's body is unavailable and inaccessible because they're strapped down, and you have to basically reach over the patient to get to them. And if there's really not a whole lot of room for the patient to move, there's not a whole lot of room for the flight crew to move, and you're basically seated providing medical care the entire time. Imagine trying to establish an airway here. I'm not doing that. Imagine doing CPR. That's not fun. You're basically going to land at your closest airport, pull the patient out of the aircraft to do CPR, because doing it on board the aircraft while it's in motion is not a great idea. All this is a long way of saying that imagine trying to do a neuro exam on this patient while they're on board the aircraft. Really not that feasible. This is the back of one of our EC-135s, our helicopters. Managing an airway in this, it's not fun. I've had to manage an airway in a helicopter before. I don't want to do that again. Most patients get intubated for transport, and that's a safety issue. If they lose their airway mid-flight, that is badness all around. That's not something that you want to have to deal with. This is where the patient's getting loaded in. And again, very little to no room, even as the patient's getting moved in. So not ideal scenarios. When you want the patient packaged up, you want everything done on the ground before you load the patient into the aircraft. Doing a neuro exam in flight really is not going to happen. It's fine if the patient's awake, conversant, calm, not afraid of flying. That's an easy patient to transport. A patient with a TBI, a patient who's intoxicated, who may be a little disinhibited, who's not really following commands, who's not listening, those are challenging patients to transport, and they may not be safe to transport unsedated. If a patient starts rocking around, moving around, that can bring down a helicopter. That's not ideal. And so some of these patients, you have to sedate them for transport, and there goes your neuro exam. Reaching remote body parts is hard. We saw that photo of the patient sitting in the aircraft and their entire left side of their body is unavailable. So if the left side of the body is what you care about, that's going to be really, really hard to examine closely mid-flight. Even talking to the patient is hard. It's really loud in the back of a helicopter. And even having a conversation with the patient can be really challenging. There are adjuncts to exams. Pre-hospital optic nerve sheath diameter is being done in Michigan. It's being done here. And it's there, it's feasible, it can be done. But again, that's another piece of equipment that you have to have on board. You have to have people who are trained and able to interpret the data. And ultimately, it's not a replacement for a neuro exam. Pre-hospital pupillometry is available. It's a thing that could be done. It's not really done that often, but it is a small enough piece of equipment that could be put on board an aircraft. But again, it has to be charged. It has to be available. You have to have the patient-specific adapters on there for it to record the data. Again, lots of equipment that you need. You have to have people trained on how to use it. And ultimately, is it worth the hassle of doing that in patients that are probably just going to be sedated and transported anyway? So again, you got to weigh all of that. And again, none of this is the replacement for a good neuro exam. Lake Sammamish, beautiful, beautiful part of the country. So let's talk about some of the physical issues that occur on board an aircraft. Vibration is a big deal. Things can get jostled, things can move, IVs can be lost. This is one of my favorite studies in all of medicine. This was Young doing a TBI model in pigs at Cincinnati in concert with the Department of Defense. And they basically took a bunch of pigs, gave them TBIs, and then shook them around. And showed that in pigs who had a vibration model, that largely their neural biomarkers, their cerebral perfusion, their PbTO2, their ICP, all kind of stayed the same. But obviously, patient-specific outcomes are hard to measure in that setting. So hard to know for sure, but at least from a biochemical standpoint and a physiologic standpoint, it seems to be okay that the actual vibration is less of an issue. But that can affect monitoring. If you have really sensitive ICP monitors in a patient during transport, we don't really know what the effects are on the fidelity of that data and if that ICP is actually reliable. Noise is a big deal as well. On average, about 80 decibels plus of noise during flight. A busy ER was studied at Hopkins, and their noise levels were somewhere in the 60s to 70s. But imagine a commercial flight without noise-canceling headsets and the engine noise that you're hearing. That's what our patients are hearing on board the aircraft. And that's what our flight crew are hearing. We do have noise-canceling Bose headsets that we wear, and that does allow us to communicate, but it does make it challenging. And folks are exposed to very, very loud noises, which means communicating with the patient to get a neuro exam, really not happening. It's pretty loud back there. G-forces are a big deal. Johannigman at Cincinnati looked at the effects of G-forces and ICPs and actually found that TBI patients were herniating during takeoff and landing. And these and other studies actually changed practice, where they found that patients who were feet first on takeoff had all their blood rush into their head and caused their ICP to spike and herniate. So now in the military and even in civilian aircraft, all patients are loaded with their head first. So when the litters are loaded, they get loaded in head first, and then they actually get moved in military aircraft so that they get rotated so that they're feet first for landing. Civilian aircraft don't have the high G forces for landing that military aircraft do, so this is less of an issue during landing in our world than it is in the military. But it is kind of a cool idea, and it's something that no one would have ever thought to do until the study was done, that actually does matter, that the position that the patient is transported in, which is why all of our patients are transported head first, which is why the left side of their body is completely inaccessible to us. So a patient with critical right MCA stenosis that is having a stroke, we can't examine their left arm. Patient with a big subdural or epidural on their right side, we can't examine their left arm. Even their left pupil is a little hard because you got to reach over and look at their eyeball. So things to think about. This makes it a little bit more challenging to transport. Finances are a big deal, and something that we don't talk about a lot. It is really expensive to fly a patient. And oftentimes patients get bills from for-profit companies that can be in the tens of thousands of dollars. Insurance won't cover it because it's out of network, and so now these patients are left with $20,000 to $30,000 ambulance bills. CMS reimburses somewhere in the several thousands of dollars range, and with balance billing, a lot of these for-profit companies will go after the patients for the remainder of the bill. Fortunately, Airlift, being funded largely by UW Medicine, is nonprofit and thus doesn't do that. But some of our competitors are for-profit endeavors and thus don't have that ability to do that. It also matters in terms of distance. The further you fly the patient, there is an inflection point where it becomes really expensive. Obviously, the further out you fly them, the benefit does exist, where it's more cost effective and efficient to fly the patient. For example, if you're coming from Forks, Washington to Harborview for a major trauma, you're going to fly that patient. It's insane to even think about driving that patient anywhere. So, when you're talking about those large distances that we have here, it's important to actually think about that and say, okay, we're going to fly this patient. The cost is less relevant, but flying them from Olympia to Harborview, maybe. Flying them from Valley to Harborview, that's just absurd. You can put them on board an ambulance and get them there just as fast. So there's no reason to charge a patient for a helicopter bill if you don't need to, and if it's not going to matter. And we talked about this before, that time-sensitive interventions may or may not affect outcomes, but it really doesn't seem to affect the cost, that the cost-benefit analysis of those time-sensitive interventions may not actually be relevant, and that the excess cost of a helicopter transport may not be warranted for a lot of patients, especially because of how expensive it can be. Finally, the safety issue. This is, while we do enjoy unprecedented safety in modern aviation, especially compared to the 70s and 80s, it is still not perfectly safe. And while accident rates have dropped over the last several decades, it's still not zero. It can get pretty close, and we got lucky in 1990, but it's still not zero. And when you look at all aviation in general, being a private pilot, this is something that my mother will never ever see. General aviation is, while reasonably safe, not perfectly safe, and helicopter EMS is just as dangerous. There are fatalities that occur. Even in Part 135 schedule, that's your airline traffic, not 100% safe. It's very safe, but we all hear the stories of airplanes going down. There was recently one in Nepal that just crashed, and the horrifying video that was recorded by a passenger on the aircraft is circulating all over social media. So planes do crash, helicopters do come down, and in terms of sort of dangerous occupation, we are not as dangerous as loggers, roofers, or hunters. But aircraft pilots and flight engineers are up there in terms of how dangerous this can be. And flight crews who practice in the air are on that list as well. There are ways to improve the safety. Dual engine aircraft are much safer than single engine aircraft, and all of our aircraft that we use at Airlift are, the rotor wing aircraft are dual engine. Instrument ratings do help. It helps fly in less than ideal weather, and pilots who are IFR trained and aircraft that are IFR certified are safer than flying just by visual conditions. And we have an improved safety culture now that we didn't necessarily have 20, 30 years ago in aviation. At Airlift, there's a 2 to go, 1 to say no policy, which means at any point in time, any individual who sees something, who observes something can speak up, and that flight is scrubbed. We had a near miss recently. Fortunately, everyone was okay, and there were no injuries, there were no fatalities, and no patients were being transported. But it very well could have been a big deal had it not been caught. And external financial pressures are still present. As I said, we at Airlift are nonprofit, so that is less of a deal. But some of our competitors have these external financial pressures that cause them to fly in conditions that may be less than ideal. And unfortunately, as a result of that, we see devastating news like this. And this is just from this past year. This is just 2022. And the fact that there's this many crashes still happening is really, really sad. And so what I tell folks is that whenever you make the decision to launch an aircraft to transport a patient, everyone on board that aircraft is happy to do it. We're privileged to do it. It is what we enjoy doing, and we're happy to take that patient to get definitive care. But if you launch an aircraft, you are now responsible for the lives of 3 flight crew plus that patient. And so when it goes down, and they do go down every once in a very rare while, it is absolutely devastating to see this happen to our colleagues. So on that note, I'll close by saying that it's not as simple as just, yeah, send them over, we'll take care of the patient, no big deal. You know, we want to get patients to definitive care. We are the major level 1 center. We are the major comprehensive stroke center. We are the neurocritical care center of excellence, so to speak, in the region. We want these patients. Patients deserve to get the high quality care that we provide here. But transporting them is filled with a lot of logistical considerations, medical considerations that need to be thought about before just putting the patient on board a helicopter or an airplane. One option is also to say, if you are worried about something, please communicate that with your flight crew. Ask to be connected to Airlift, ask to be connected to, when you're talking to the local facility, ask them to pass the message along. This is what I'm worried about. These are the things that I want to make sure that they watch during transport. And sometimes that means, hey, you know, it may take a little longer, but we're going to transport this patient by ground because it's really, really important for us to follow their neuro exam. Or, you know what, just sedate them, intubate them, just get them here as fast as possible. I've got the OR ready. We've got a big subdural here with shift. We need to get them decompressed as fast as possible. Time is of the essence here. Maybe that's the important thing, but talk about what it is that you're worried about for that patient and why getting them here in a specific fashion is important. And the transfer center and Airlift and the flight crew will make it work. And finally, if this is really cool and you are super excited about this, please feel free to email me. I'll get you connected, but contact our flight crew and we're happy to take you on for ride-alongs anytime you want.